I can share my screen. All right. Can you make me co-host, Andrea? All right. Can you see my screen? Okay. So today I'm going to be presenting a case with Dr. Barsukova. Unfortunately, Dr. Barsukova wasn't feeling very well this morning, so Dr. Shaliz will be stepping in to help out. So without further ado, this is the multidisciplinary team that was involved in the care of this patient. So as you can see from neurosurgery, we have Dr. Q and Dr. Almeida. From ENT, Dr. Donaldson and Dr. Janis. Endocrinologist, Dr. Sampson. Neuroimmunologist, Dr. Lopez Chiriboga. Neuro-onc, Dr. Sherman. Radiology, Dr. Vibute. Dr. Genta from pathology, and neuro-ophthalmology, Dr. Eggenberger. So this is a 30-year-old man who actually was in his prior state of health, healthy otherwise, until in March of this year, he had an episode of very severe headache, nausea, vomiting, and before he noticed, he woke up in a hospital. He was admitted. They suspected meningitis, did a lumbar tap. There was no signs of any growth on cultures or any signs that would point towards infection. So a presumptive diagnosis of a chemical meningitis was made at this point. The patient at this point is referred to our center, first evaluated by telehealth. And when the full history starts being reviewed, we understand that this patient had a similar episode 4 to 5 years ago, but otherwise his medical, surgical, family history is unremarkable. And he comes with an MRI that shows, as I'm going to show in a few slides, hypothalamic lesion that is enhancing. And at this point, the multidisciplinary team starts evaluating this patient, as you can see. And this is just the exam on one of his first evals that were done here in person at Mayo. And as you can see, otherwise normal. This is the endocrine labs. I don't know, Dr. Shaliz, if you want to comment on this.
Yeah, so on the endocrine labs, the cortisol was just slightly on the lower end of normal, is 7.1. The ACTH was 13, DHEAS was within the reference range at 259, and the IGF-1 was 213, so again within the reference range. The TSH was 0.94 with a free T4 of 1.4, and the FSH and LH looked to be kind of, when you compare them to the testosterone, so you see that the testosterone is a little bit it's low. And so you'd expect the FSH and LH to be, well, the LH specifically to be higher if the pituitary is responding appropriately. So this is like I would say like a falsely normal, inappropriately normal LH in comparison to the testosterone. And then the ACE level was slightly elevated, it was 69 with an AFP that was low, which is good. And that was 0.9. He also had an ACE level done previous to this as well, and that was 19, so within the reference range. And he's had like HIV testing that was negative, syphilis testing that was non-reactive, and then CSF studies too that showed like negative AFB and negative cultures as well.
What do you think of the prolactin?
Oh, sorry, I forgot to mention the prolactin. It was slightly elevated. It was 29.5. So when you look at that, you'd think that this is probably like stock effect as to what's going on, is at least from the rest of the story that we're seeing, or it could be, I guess, like a prolactinoma, but I doubt that just given how complicated this case is.
Well, I don't know if I'd use the term stock effect because we don't really have a pituitary lesion. You have a hypothalamic lesion. So there's been some dampening of the dopamine signaling to the pituitary. So that would be the explanation. We use stock effect when we think about the stalk being disrupted by a mass.
And Dr. Sampson, I think she also did ACE on CSF, which was also normal at the other institution.
So the ACE in the CSF at the other institution was mildly elevated, but the serum was normal. And then at our institution, it was just mildly elevated again and could be a false positive or a true positive as part of the differential.
Thank you. And I don't know if Dr. Eggenberger is on the line. I think he is. Dr. Eggenberger, would you like to comment on your evaluation?
When we saw him, his afferent function was normal. But as you can see from the OCT, he did have some disc edema of the left eye. And you can see that on the tracing on the right.
And I also have these pictures that you took also. I don't know if you'd like to comment on them.
These are the laser Aptos photos. And this is just a way to capture the more peripheral retinal details. But I really think the OCT shows the nerve better. This is the autofluorescence. Well, pretty normal.
So just slight disc edema, but otherwise fairly normal. And
Correct.
this is the MRI that we first have access to. And I have here the coronal, the sagittal, and the axial. And I'm going to show you here the lesion, as you can see, enhancing third ventricle hypothalamic, but one that is a very interesting finding that we can better appreciate on the sagittal, and I know Dr. Prezan is also on the line, so I'll ask him if he wants to comment, is that there is this leptomeningeal enhancement that goes all the way down almost to the cervical spine. And Dr. Prezan, I don't know if you want to comment on this also.
Yeah, sure. Actually, do you have other sequences like T2 and flare, or is that the only sequence?
I do. No, I do have T2 on the next slide.
Okay,
you want me
all
to
right,
go
that's
there?
fine. Let's look at this first, and then obviously as the diagnosis is made, you can see there is a big lesion in the hypothalamic area just below the third ventricle, and the lesion is not entirely enhancing; it is heterogeneously enhancing, and there are a lot of leptomeningeal disease caking the brainstem and going down all the way to the spinal column as well as in the fourth ventricle. And it's also seen along the fifth nerves. You can see it on the axial views, and it's all around. So it's definitely a leptomeningeal spread of something coming from the hypothalamus. I'm saying coming from the hypothalamus because hypothalamic lesion is the most dominant one. But based on this alone, it's very difficult to make the diagnosis. Whether we can make a differential diagnosis based on the T1 post. You can think of, germinoma, which is a classic location. Again, this patient is not very old. So that could be a fair diagnosis of just looking at the T1 post contrast. But then if you look at the T2, that doesn't fit the germinoma because you can see on the coronals, the lesion is predominantly hyperintense, except for central portion of low signal intensity, which was the one which was enhancing. And that high T2 signal is almost close to CSF. It's not very dark. It's not exactly like CSF, but it's very bright for a germinoma or lymphoma or any other kind of tumor, except for one tumor, which is pilocytic astrocytomas. They tend to be very bright on T2. That's one thing which gives away. Other thing, what you could consider, is in this location, because there's a talk of ACE and neurosarcoidosis. That's a good location for neurosarcoidosis. And obviously, leptomeningeal disease is very well known with neurosarcoidosis, but the only thing which doesn't go along with neurosarcoidosis is the enhancement. Everything solid in germinoma and neurosarcoid should enhance entirely. And here you can see solid parts are not enhancing completely. Other thing, as I pointed out, in neurosarcoid, the lesions would not be as bright as CSF or very bright on T2. And on neurosarcoidosis, typically, when you have brain invasion or brain involvement, you'll see some edema of the brain and you don't see anything here. So no inflammatory process going on within the brain parenchyma. So that doesn't favor neurosarcoid. So location-wise, it's very typical for all three of these, but appearance-wise, if you take the dominant lesion, it's very typical for pilocytic astrocytoma. The only thing which doesn't go with pilocytic astrocytoma because it is WHO grade 1 is the leptomeningeal disease. But we know that pilocytic astrocytoma can spread, especially superficially located. They can have leptomeningeal extension. And so that is the leading diagnosis in this case based on imaging.
Prasanna, can you comment on two things before we just leave that? Go back to the sagittal. Number one, comment on the pituitary, because he's a young man. He's only 30. Go back to the sagittal, probably the contrast enhancing sagittal, Diogo. And then comment on the issue of a craniopharyngioma, because when this patient was sent to us by one of my colleagues in the Atlanta area, their leading differential was a craniopharyngioma. So can you comment on those two things and why were they thinking that way?
Yeah, it's suprasellar, very typical location for a craniopharyngioma. The pituitary gland itself looks normal, and that can happen with craniopharyngioma. Right? It means a pituitary gland will quite often be normal and located in the sella, but above that, that's a craniopharyngioma. Now here on the sagittal, it's very difficult to tell it apart from craniopharyngioma. I mean, you would expect craniopharyngioma to be cystic, more or less. Of course, you could have solid types, but what is not typical for craniopharyngioma is again the T2 appearance. So on T2, it's craniopharyngiomas, as we know, can be bright if they're cystic. But if they're solid, then you would expect them to enhance. And here, what is solid is not enhancing completely. So on the sagittals, it's very difficult to tell them apart. You can think of this not being cranio just because it is so nodular and so solidly enhancing components to the tumor. So putting together all the sequences, you would not think of this as a craniopharyngioma.
In the pituitary,
Uh-huh.
No, thank you. No, the pituitary, you said it's normal, but he's a 30-year-old patient. It seems to me, I don't know, Susan, he's a little bit in the small side.
Yeah, that is correct. No, I'm saying normal in the sense it's not mass-like.
Gotcha.
Yeah.
So
it's not a primary pathology of pituitary gland.
I got you. Okay.
Yeah,
So
sorry.
Susan, would this be an indication that there has been something that has been playing a role in the normal size of the pituitary over time, or what are your thoughts about that?
I mean, it's a great question. Was there interruption of hypothalamic trophic factors coming down to the gland? And so you see that reduction in size. It does look shallow. As Dr. Shulis presented, the thyroid axis was normal. The prolactin was a little bit elevated, which could explain the low T. The cortisol, adrenal axis was normal. So he hadn't manifested hormonal deficiencies yet of this area. The other thing that was surprising to me is with all this going on that he didn't have diabetes insipidus either. So that speaks to perhaps a lack of infiltration into the stalk of whatever this lesion is, which we didn't know at the time. So I do hear what you're saying. I think there probably was some interruption of that signaling, but somehow he was still managing to keep his axes intact other than the prolactin and the testosterone.
I believe if this is a very slow growing tumor, then you would expect the pituitary gland or other, to compensate slowly. So maybe because the nature of the tumor was so slow growing and indolent that over a period of time, the patient compensated.
All right. So as you can see, multiple differentials still at play at this point, and I'm just going to go ahead to just a summary here. So just to make a quick point, a touch point on where we are, we have a young man with otherwise healthy, had an episode of an headache, was presumed to have a chemical meningitis, comes with this lesion, hypothalamic, hyperintense on T2 with partial enhancement. And the differential at this point includes multiple conditions. We've heard that it could be potentially a sarcoidosis, other more rare diseases like Langerhans cell histiocytosis, germ cell tumor, other infiltrative granulomatous diseases, particularly lymphoma, even though he's young, hypothalamic glioma, like Dr. Prezan also mentioned. But given the fact that it is a potential for a sarcoidosis at this point, the consideration for extraneural lesions without symptomatology was raised, so the patient was actually taken to a PET. And I'm going to show you here the PET next. And I don't know, Dr. Prezan, if you also want to comment, but there's quite a lot of uptake here in the cervical lymph nodes and also in the nasopharynx. So I'm going to go up just to show that. And below you can actually see some of the lymph nodes lighting up.
Mm-hmm.
So at this point, actually, the team considered that potentially this could be a systemic disease with involvement of the lymph nodes, and the patient was taken actually for a lymph node biopsy with Dr. Janis. And that biopsy came up as normal, so just hyperplastic, follicular hyperplasia, so no signs of involvement by any granulomatous disease, so potentially decreasing the risk for sarcoidosis, even though, of course, we cannot exclude that without a biopsy of the actual lesion. Patient was also evaluated by neuroimmunology, and the consensus at this point was that if the lymph node was positive, sarcoidosis would become the presumptive diagnosis. By that meaning, if we find a granuloma, if not, then we have to proceed with a biopsy of this actual lesion, the hypothalamic lesion. So because we do know that the biopsy of the lymph node came up as normal, or at least not involved by any granulomatous type of disease, the patient was taken at this point to an expanded endonasal approach, as I'm going to show on the operative video next. I don't know if anyone has any comments at this point before we proceed with the surgical video.
I just wanted
quickly,
to go ahead, Prasanna.
Yeah, quickly, the diffusion weight sequence is very important to exclude or at least favor lymphoma or germinoma. You would expect that to be, restricted on diffusion. And in this case, the diffusion is very facilitated. So it tells you again, it's a very, the pilocytic astrocytoma are very facilitated on diffusion. They look very, very bright on ADC. So that again did not favor lymphoma and germinoma. So that's what I forgot to mention. Sorry. That's all. Thanks.
And I just want to mention that the amount of work that Dr. Sampson, Dr. Sherman, Dr. Lopez, us, I mean, this was truly an extensive amount of work that happened over the course of a week or two, discussions, multiple meetings before we decided to do what we're about to see in the video. Susan, anything to add? Because these are the kind of cases that we get extraordinarily complex, difficult diagnosis in patients that need our help. Go ahead, Susan.
Well, just a minor comment of, the timeline of all this. We heard Dr. Vibhudi's excellent read of the MRI. And you might say, well, why were you doing a PET? And why were you looking for something to biopsy that was easy? That, in fact, predated his excellent interpretation of the later MRI. And so we were really flying with what we had, which was an ACE level that maybe was a little bit elevated, some lymph nodes. And so that was really the timeline. And perhaps we should have repeated the MRI earlier. I'm not sure, but it was very challenging to come up with the diagnosis. So the next step definitely needed to be the biopsy.
That's right. And also we are working and I haven't seen the report of the MRI, but the reality, and Dr. Vibhuti knows this, in retrospect, we can always come up with the diagnosis. Prospectively is not the same. And Dr. Vibhuti and I always tease them and Dr. Gupta, once we look at this, we're like, oh yeah, this is what it looks like. But when we're looking at the differential diagnosis, if we look back at the notes, even of our neuroradiologists, as good as they are, many times they have everything else, in the diagnosis, and that's a reality. I see Gaetano laughing, but I do tease them. It's for all of us. I mean, this is why it's called a differential diagnosis.
That's right. That's right.
All right. So this is just a preoperative CT that was obtained also by our colleagues in ENT for the planning of the approach. And since we're going short on time, I'm just going to proceed with.
So as JP said, Q and I had a discussion in JP at the time of frozen. And because of that discussion, I favored pilocytic at the time of frozen. The frozen section had a lot of artifact due to edema within the tumor, causing basically freeze artifact. However, given the location, what I was seeing, my discussion with Q, everything fit best for pilocytic. It's always nice the next day when the permanent sections come out like this and confirm your suspicions when you're not 100% sure. This shows all the classic features of a pilocytic astrocytoma. You can see the cells have round nuclei, almost have somewhat of an oligodendroglioma type look in areas, which is a feature of some pilocytic astrocytomas. It has the classic Rosenthal fibers. A few of those are highlighted here by the red arrows. And it also has what are called glomeruloid-like vessels. In other words, vessels that are clumped up. And you can see on the left-hand side of the screen there, the half circle circling that area of that clumped up area of vessels. So this had all the classic features of a grade 1 pilocytic astrocytoma. And we do have some molecular testing. Dr. Sherman wanted some testing on this, so we have some BRAF testing pending. Just to show, these are GFAP positive, so yes, it is a glioma, and they're devoid of axons in areas, so it has a solid pattern of growth, not an infiltrative pattern of growth. What you see, the pigment you see there on that neurofilament stain is actually hemosiderin pigment that is present and not actual staining. So again, grade 1 pilocytic astrocytoma.
Thank you, Dr. Genteth and Dr. Almeida. So this is the post-op labs. I don't know if Dr. Schulis, if you want to comment on the progression of the labs.
Yeah, so the post-op day 1 labs, the cortisol was 1.2, but there was 10 milligrams of dexamethasone that was given in the OR the day before. So this is kind of what we were seeing, I think, with the drop in the cortisol. But the patient was still discharged because the following day there was still some low cortisol on hydrocortisone, just given the extent of, just given that the cortisol was still low on the second day as well. And then on post-op day 8, the cortisol was still kind of on the lower end, so stayed on the hydrocortisone, and the TSH and the free T4, those are probably the most meaningful here, were low. So that shows a secondary hypothyroidism that needs treatment as well. So the patient was started on levothyroxine as well. The interesting thing with this patient was that they did get 2 doses of DDAVP while they were in the hospital because there was increased urine output. When you look at the sodiums, they were like 140, 144, and then 139. On post-op day 8, it was 124. And then on post-op day 12, it came back up to 135. This dip might have resulted in the fact that they were also started on acetazolamide, and acetazolamide can cause an increased secretion of sodium, and it's used actually sometimes for patients that have lithium-induced nephrogenic DI. So it's like one of those treatments that can be used. So it might have led to more sodium excretion than we'd accounted for. The patient was discharged on DDAVP, but it sounded like, based off of the notes and what I've heard so far, is that he didn't even take them and was drinking to thirst like afterwards. So I think once the acetazolamide comes off, it's kind of a mixed picture. Then I think we'd be able to decide on whether he has true DI or not.
Yes, he did have DI, and in this case, as you know, when we don't have DI, we look at fluid restriction to prevent hyponatremia as an outpatient. I did manage him daily as an outpatient. I think he took 1 dose as an outpatient, and then we watched to see if the DI resolved. But the acetazolamide did cloud the picture, as you pointed out. It can actually treat DI. I still think this might have been a mini triphasic response. And when we saw him in clinic this week, he had polyuria, but his sodium didn't support that he was going into that 3rd phase of diabetes insipidus. And I mean, although this timeline comes after surgery, we're seeing changes in his hormones that are not explained by a hypothalamic biopsy. I think this is progression and interruption of that communication with the pituitary. And he's now adrenally insufficient, as well as having secondary hypothyroidism. So I think all of that has contributed here.
Do we know why the 10 of Dex was given? Was there a surgical reason, or was this for the whole nausea thing, which I thought we were trying not to do?
So the nausea dosing that anesthesia uses is often around 4 milligrams. And I think in this case, this really was asked for by neurosurgery because he did have some edema in the mass. I can't answer, but I think there was a good neurosurgical reason for the Dex.
Okay, just curious.
Dr. Q or JP could maybe answer. We can move forward.
Okay. So I don't know why it's not allowing me. Okay. So the patient was discharged on postoperative day number 2, doing well. I don't know, Dr. Simpson, if you want to comment on the meds he took after discharge. But otherwise, the patient, sorry, go ahead.
Yeah, no, we kind of discussed the hydrocortisone as well as the acetazolamide as the discharge medicines.
Okay, and the plan at this point is to have full neuroaccess eval to evaluate potential dissemination, cervical, thoracic, lumbar spine. BRAF is pending. If negative, there will be consideration for craniospinal radiation. And here we just have the post-op imaging showing the resection of the lesion. I'm going to go back lower, and here you have the sagittal. And because we're already past time, I'm just going to proceed to stop sharing my screen. I don't know if anyone has any last minute comments on this case, but otherwise. We'll
I had a couple of questions for JP, if that's okay. Can I ask quickly? One is that, we know that it was an extensive disease, leptomeningeal, and there was a primary lesion probably in the hypothalamus. So obviously the intent for surgery was just tissue, obtaining tissue. So would you consider stereotactic biopsy minimally invasive? That's one question. And the second question I have is that it's an anatomical question. If the sphenoid sign is not completely pneumatized, it has a pre-sphenoid type of pneumatization, then what kind of landmarks you look for? Like, because, you showed the carotid artery, the recesses and the pituitary gland impression and everything else. So do you use stereotactic imaging to guess where the landmark, to see where the landmarks are?
Yeah, I mean, absolutely. So for question number one, I would not consider stereotactic biopsy as as an excellent option, just because, crossing the ventricles and getting that control and getting the amount of tissue that sometimes is necessary to provide with, a diagnostic of this, I would feel much safer and much better control with an endoscopic in the nasal that, we did minimal manipulation in the nose, in my opinion, and we didn't see the brain or anything. So I consider this, in this specific case, quite minimally invasive as well. So the trajectory of a stereotatic would potentially require to go, through the ventricle, like even if going subfrontal, you're still going to be working near, some perforating branches. So I wouldn't really kind of advocate for that one. Although one can say the opposite, say well, with hypothalamic hamartomas, you can go stereotatically and do laser. So it is my personal opinion for locations in the hypothalamus. In terms of the second question, with the exception of very young children with really a lot of bone in the sphenoid, to go with, the endoscope allows you to usually find some landmarks. The primary one is always the sella. But in cases where you really have a lot of ossification there, like in fibrous dysplasia, or for example, you can definitely benefit of stereotatic navigation. But even in those cases, the first thing I do is to find the sella. Once I design the sella, kind of you can get the imprint of the 3D anatomy in your head, and you can basically expand laterally. But yeah, stereotatic navigation and a microdoppler help quite a lot in those cases.